size. And Jeffrey will introduce a little bit more ISPN, and I will be back to introduce our moderator, Spyros. Please, Jeff.
Thanks, Nelsie. Thanks for the opportunity, and welcome to everybody to this Clash of the Titans. As I think everybody is a little bit aware, but I'll just recap for those who aren't. The ISPN Education Committee basically carries on 3 levels of instruction, right? One is a monthly webinar for junior doctors and medical students that's available on a web Zoom webinar. We have some live courses in different countries around the world, and then this forum, which is one of the most popular. This typically features 2 people at mid or senior level with experience and accomplishment in pediatric neurosurgery, embracing a position sometimes a little bit farther than they might particularly embrace for their own practice, but for the sake of argument, for the sake of development of the one side. They are typically focused on areas of controversy in pediatric neurosurgery, perhaps uncertainty. And today we, of course, have a special treat that Nelsie will introduce. A brief word on ISPN. It's the largest pediatric neurosurgical organization in the world because it takes under its wing all of the smaller unit organizations that are unique to specific countries. And a quick plug for the guide before I turn it back to Nelsie. The guide is an online reference and resource for anyone taking care of children. It updates regularly, and we're in the midst of a major update and overhaul on it right now. The mission is to have something that is practically useful for somebody providing immediate pediatric neurosurgical care for a child somewhere in the world and seeks to review some information, review how things are done, review these types of things. So that's the neurosurgery guide, also available through the ISPN website. Nelsie, back to you.
Thank you very much, Jeff, and thanks, Jay, Riva-Cambrin, and Benedetta Pettorini for being with us and give us your time and your energy. I will introduce Sgouros, a very large curriculum. Is assistant professor in neurosurgery in Medical School National and Kapodistrian University in Athens, and head of Department on Pediatric Neurosurgery, Children's Hospital, Athens. He studied at the University of Athens, do neurosurgery in Britain, specialized in pediatric neurosurgery in craniofacial, training in Paris, Hanover, fellow in Royal College of Surgeons in Glasgow, and doctor in medicine at University at Birmingham. It's not all. There is much more. He works consultant neurosurgeon in Birmingham Children's Hospital and returned to Greece in 2007. Member of many international neurosurgery societies and part of this executive board too, and president of IFNI and also European Society on Pediatric Neurosurgery, and editorial board member on Children's Nervous System and other journals with more than 140 publications, 32 chapters in books, and more than 100 abstracts in the meeting. I got the privilege to meet Spyros in Birmingham in 2000, and he told me the meaning of the word true. I just got married at that time, that week. I was there by myself. And Spyros funny asked me, did you trust him? And I tell him, yes. And 20 years after, I still married. And his fun moon, it's always a good partner in this work. He is also a good friend, sailor, amateur, photographer, and musical lover. Thank you, Spyros. The stage is yours, and please introduce our friends' works today. Thank you.
Nelsie, thanks very much. All things you've said about me, I've almost forgotten all of them, and I have to disclose worldwide, I'm not as old as all these things make me sound, okay? I think really the most important thing of all these things you said is that the ISPN is a great family of friends, and I learn more from going to the ISPN meetings all these years than reading papers and all that. I think it's a community of pediatric neurosurgeons, and with Jeff and with Jay, we go back a long way, and Benedetta, we go back a long way. As you said, we've met many years. But you said 2000 is more than 20 years ago. Time flies, crazy. Still, today is the big question: does size matter? And and on this big question, does size matter? we have a big clash. A lady and a man who will talk to us if size matters. Okay, let's see what they're going to say. Benedetta, of course, is of Italian origin, but she's making great career in Liverpool, UK. Okay, she's a consultant neurosurgeon in Liverpool, UK. Big profile. I think everybody knows her. And Jay Riva-Cambrin is in Calgary in Canada. Very big profile in hydrocephalus. I think most of you have read all the publications. I think we'll have Benedetta go first. If all these Clash of Titans, I think is a little bit artificial. You have to take a state, you have to take a side for or against the actual title. But I hope our two contestants will elaborate on the topic, but because I think the elaboration is what matters, not the straight position. I'm in favor or against. I won't say anything further. I'll let Benedetta go first. Dr. Benedetta Pettorini, who, although practices in Liverpool right now, she just told us she's in Paris, visiting Necker Enfants Malades. I don't know why she went to Paris at this time with all these strikes and everything, but she looks very well, as you'll see. Benedetta, you have the microphone, okay?
Yes, thank you, Spyros. Everything is quiet in Paris, actually, so I think I'm safe enough. I've been invited by the lovely friends here, so they are connected as well, all here, all friends. So as you said, Spyros, correctly, you can see my screen, yeah?
Yes.
Yeah, lovely. It is not necessarily about having, as I said, fixed positions in the Clash of Titans, but it's more to touch on topics that we come across almost on an everyday basis in our practice. And there is always a question, are we doing the right thing, or can we learn from other people? And do we find an agreement of what is the most acceptable practice? I think that's the way I see it. I have to say, when I was given this title, I thought, yes, easy. Then doing it actually is not that easy, and is not taken for granted what the answer is here. And I'm sure Jay would agree with me that the elaboration of this topic has been more difficult than what we predicted, probably. So I decided to touch predominantly on two aspects of this. So just, sorry, I can't go. Okay, there you go. So the size, in particular the size of the ventricles, is a topic that has touched many of our colleagues very closely. A lot of research has been going in the past. I think actually probably a bit less more recently. But hydrocephalus, so ventricular anatomy, pathophysiology and treatment is literally the bread and butter of what we do as pediatric neurosurgeons. And personally, I don't think that we have done enough really to understand what's going on. And I think a lot of interest and a lot of focus has gone in treatment and technology and applied technology, but not necessarily what's behind it. And pathophysiology has always been a great interest of mine. That's why for this talk in particular, I decided to touch more on the pathological changes in hydrocephalus rather than the clinical aspects. But what is it that happens in hydrocephalus when, in the ventricles when there is hydrocephalus? But a lot, actually, and ependyma in particular, and the subependymal zone and choroid plexus are actually basically almost destroyed by hydrocephalus. There is macrophages and periventricular cells that are actually completely damaged and almost irreversible, and I'll touch on this. The white matter myelin also is damaged, and there is a lot of old research going on about this, and more recently in posthemorrhagic hydrocephalus. But the point here is that hydrocephalus is not a benign condition per se. If we only look at the pathophysiology and the damage caused to the brain overall. And what is the mechanism of injury caused by the hydrocephalus? Well, there are vascular factors, so reduction in blood flow and Dopplers and specific MRI sequences are always demonstrated it. But there are also chemical factors with extracellular water that is forced out and a movement of neurotransmitters. Again, a lot of literature around this. None of this is particularly recent. However, this doesn't change. Therefore, we always have to consider that hydrocephalus is a form of brain injury. Can these changes caused by hydrocephalus be modified or reversed? And I'm getting to the point here of the talk. So some other pathological changes can be prevented with CSF diversion, in particular at the beginning of it. So waiting potentially can actually cause an irreversible damage to the brain that could be prevented. And in particular around the cerebral blood flow, the utilization of water and glucose, and metabolic corrections. So this is all science and not opinion. However, even when we shunt promptly, the corrections are incomplete in terms of reducing or reversing the damage that has happened. So whatever we do, the lining of the ependyma is not restored, and so there is never a complete regression of everything, of the anatomy and the pathophysiology of the ventricular system. Of course, the damage is dependent on the rate and the extent, so the size of the ventricles, how much the ventricles are involved, and of course when this happens. Neonates, we all know, different than toddlers, and toddlers different than adults, really. And the potential for the reversal of the damage, as I said, diminishes as the duration and the severity of the hydrocephalus increases. So, as I said, for this presentation, I just touched two.
It's freezing.
Benedetta? Seem to
Probably the connection just goes down.
have frozen it midstream.
Yeah. I sent message to her on mobile, and maybe if she can't be online, we can switch just a moment to see if she can be back. No, she drops. Maybe
I'd give her.
we can continue with Jay. What do you think, Jeffrey and Spyros?
Well, let's give her a minute just for the sake of
Okay, she's back.
Right? I mean,
Sorry, there you go.
yeah, good job.
Okay, fantastic. Welcome back.
Wow, look at that. Amazing. Fantastic.
Okay, I'm back.
Excellent.
So posthemorrhagic hydrocephalus, we all know the optimal time is unknown. There are more recent literature. There is the Elvis trial, as we know, so early versus late. We showed no difference in terms of survival and the need for VP shunt. And post-analysis actually demonstrated that a lower threshold for the temporary diversion of the CSF is actually associated with lower brain abnormality score, which is totally relevant for this topic. And the progression of the ventricular index beyond the 97th centile should then trigger intervention. So from this, it seems that ventricular size actually is important, if nothing essential, for a better outcome in posthemorrhagic hydrocephalus. So this is the cumulative ventricular size. So this shows that the reduction of the ventricular size on its own actually is related to a better, in particular, cognitive and motor scores. And this is an evidence that we really can't ignore. In Liverpool, for example, in the northwest of England, we've done a guideline which is very specific to this, and which takes in consideration all the most recent literature. And we're actually in the UK developing a trial of what the best temporizing treatment is. But the whole principle is temporizing a shunt in posthemorrhagic hydrocephalus means early treatment, which means increased radiology, so radiology only. So increase the ventricular size on its own triggers in early intervention. And also, let's never forget that the big ventricles are not big ventricles forever necessarily. Even in complex posthemorrhagic hydrocephalus with clots around the third ventricle. This is a very recent patient of mine. I did a subgaleal shunt to start and then a definitive shunt a month later. This is the CT scan 3 months after a VP shunt with a lot of brain that we expanded. This patient is absolutely, she's a 2-year-old now, absolutely normal toddler. So we always have to consider that. So the question then is to shunt or not to shunt, and also when. In particular, if we consider now moving to the arrested hydrocephalus or compensated hydrocephalus, there are more questions than answers probably, but the main questions are, is it reasonable to follow a child with large ventricles if they're stable and they're developmentally normal? Yes or no, I don't know. I usually have a very low threshold, in particular, if the diagnosis is unknown, so I keep a very close eye on them. And does the child pay a price for not receiving a shunt? So are we allowed or not allowed to operate on scans only? We don't usually do it. However, there is always a question to be asked about what the best thing is. And also, are we talking about really an arrested hydrocephalus or a compensated one? Definitions are not always consistent. But generally, we're talking about non-progressive ventriculomegaly. So we know that if the ventricles are enlarging over time, plus or minus neurodevelopmental problems, we do have our answers. But what we're talking here is patients with stable ventricles, most of the time congenital hydrocephalus. A lot of post-ETV patients are actually got relatively large ventricles that are stable on time with a good flow. And we don't treat the ventricular size in those patients, but are we actually paying a price for not acting? So stability in edge circumference and absence of progressive developmental delay equals compensated hydrocephalus. But as I said, at what cost this compensation happens? What's the evidence? Well, significant improvement in intellectual performance actually after shunting these patients with stable ventricles does happen. So we always have to be mindful that the most important follow-up for this patient is actually neurocognition, school feedback, teachers' feedback, and we need to really make sure that we are doing our best for their neurodevelopment, because these are very subtle signs. That patient coming into clinic, it's absolutely fine, nice and smiling and playing. That doesn't give us all the answer and shouldn't just reassure us. Different risk completely, and this is very well published age-wise. So if this patient is less than 5 years of age and very big ventricles, the threshold for shunting is usually quite low. mainly because there is also such an inconsistency around neuropsychological assessments that we really need to be mindful that we are not causing an irreversible problem later on. Over 5 years of age, vigilance is absolutely more than reasonable. But what if we have this patient who has had these ventricles for 10 years, and which is this patient, and comes to your clinic and comes with headache, and no papilledema, however, some visual obscuration. So all very subtle and not convincing, but I'm very OCD, did an ICP monitoring, and there you go, very, very pathological ICP waves. And this patient, of course, needed a shunt. So we do have to consider significant improvement in intellectual performance following shunt with stable ventricles. There are a lot of investigations we can do, including infusion tests. A lot of centers do it. I see, of course, invasive ICP monitoring, flow studies, Dopplers, and they can all, in case of any doubts on a clinical level, they can actually diagnose uncompensated hydrocephalus, and ventricular size should always trigger this. And vigilance is and should always be the rule in any case. And that's it.
It's a really nice discussion.
I'll stop sharing.
Yeah, it really sets the stage really, really well. Thanks for those comments. Spyros?
Benedetta, was a fantastic talk. A lot of information you packed in. While Jay's getting ready, if I understood you, for you, the most important thing is when was the actual event happened, rather than how big are the ventricles, correct?
Yeah, so my point is big ventricles in a stable patient shouldn't just reassure, because that's the principle, right? So my point is we always have to question what we are seeing and ask the right questions.
Fantastic. I'm sure the 87 or whatever, the 90 participants we have will have many questions to ask you later, but Jay is going to follow now. Dr. Jay Riva-Cambrin. Yes, it's finishing. Jay, over to you.
Okay, great. Thanks. That was great. Can you see my screen?
Yes.
Mine's weird. Okay. Okay, great. So as Spyros says, I've argued my whole life that size doesn't matter. So that's for Spyros. So anyway, so I have to argue that it's this is correct, that this is a single negative, not a double negative. So let me just, okay. All right. I also want to disclose, so you might hear me use, I go on and on about this. I don't use the term hydrocephalus unless it's pathological. So ventriculomegaly, if I use ventriculomegaly, that means I don't think the patient's asymptomatic, but I won't even give them the moniker of hydrocephalus. So there's, in my opinion, in my practice, there's no such thing as untreated hydrocephalus. If you have had hydrocephalus, you're treated, just for some semantics. Okay, so I thought it's best to just look at this from a case study, just to like really drill it down to like maximal clinical utility. So untreated ventriculomegaly. So here's a case. So and we've all probably seen this, 9-month-old boy, myelomeningocele, prenatal, closed in Toronto, and but moved back to Calgary where he lives. And then no concerns except for a largest head. You can see the OFC there crossing percentiles. However, fontanelle's soft and flat. Development is right on track, except for gross motor because he's a myelo. But feeding well, mom's great, mom's happy. Here's the ventricles, not dissimilar for some of the ventricles Benedetta showed. I'll just point out, so he's prenatally closed and complete reversal of the Chiari. Okay, so just already doing a summary. So just to highlight, so he has no signs or symptoms of raised intracranial pressure. His OFC is slightly up, worrisome. Development's on track, great. No syrinx, great. No sulci gyro effacement, great. However, he does have significant ventriculomegaly. His frontal occipital horn ratio is 0.53. So that's angst. So exactly, I'm on the same page, Benedetta. So what is the ultimate goal? And so I think maybe our forefathers chased some of these things, like a normal head size. Or do we just want normal ventricular size, nice pictures? I don't think we live in that era anymore. I think we live in this era. We live in the era of patient-centered outcomes. So what really matters is quality of life. Examples of that is ABCO Carney's hydrocephalus outcome questionnaire, cognition, and really the number one question I think we all get from moms and dads is my child going to be gainfully employed? Is my child going to university? Are they going to have a job? Are they going to be a fully member of society? And to that point, I mean, there's organizations in the US, there's a similar one in Canada, I'm sure Europe, all over Asia. I think everyone has research institutes like PCORI, where it's patient-centered outcomes. So they're looking at studies with patient-centered outcomes. So again, parents agree that cognition is the primary goal. This is a great study by Mandeep Tamber and Rob Naftel that kind of looked asking parents of children with hydrocephalus, and would they trade off more surgeries if their child had better cognition and better improved school performance? And absolutely, they'd take more operations, they'd take more short-term pain for long-term gain. So parents agree. So let's just have a gander through the literature. Most of the literature for this talks about treated. My case is untreated, but we got to look where there is literature. So treated big ventricles and see if it leads to worse outcomes. So first study, remember our kid's a Milo. So there's a great study, Ben War from Africa in Uganda, and looking at in Milos, children that a little bit older, and they used the Bailey score. We'll get to that in a minute. And they found that larger ventricles were in the shunted kids, not that surprising. However, when they looked and they adjusted for procedural type, they found no association between ventricle size and cognition. Well, people can easily dismiss that. Oh, it's BS, it's the Baileys, it's Africa, it doesn't apply to westernized countries. Okay, well, here's ABCO Carney and Ruth Donnelly. It's hard to argue with those titans. It's retrospective, North American, aqueductal stenosis, a cleaner population, and full-scale IQ. So they really were looking at ETV versus shunt and found no difference in cognition. But a secondary outcome of this study, we looked at ventricle size and IQ, and also found no association. Again, though, relatively small. You can't talk about this stuff without talking about Steve Schiff's work. This is some early work in Africa, again in Uganda with Ben and Ab, looking at Bailey's. And as we know, Steve's obsessed with brain volume, and rightfully so, and found a little bit of a signal that brain volume might predict cognitive, but ventricle volume did not. In other words, ventriculomegaly. So again, negative. Now, this literature is limited because most of these studies are retrospective. They're usually selection bias. So anytime we're dealing with neurodevelopmental or neurocognitive stuff, most of the old studies had the patients, like they decided to do the study 5 years later and call patients in. Not all patients would come in. You can imagine they're the ones that have deceased are not coming in. Those that are doing really well maybe don't want to come in, or those that are doing very poorly can't come in. So there's a lot of selection bias. And in most circumstances, these were not multi-centered. So what do we always say? We need a randomized control study. So we got one, New England Journal, ABCO Carney. So 2017. So we should all know this study. Uganda, less than 6 months. They're all post-infectious. Now, the purpose of this study was to compare shunt versus ETV, but the important thing is their primary outcome was cognition, again, BSID, the Baileys, and we all know it showed no difference. But as per today's talk, this is what I want you to focus on. So the ETV CPC group, not surprising, maintained bigger ventricles than the shunt group. You'll see though, brain volume, Steve Schiff's brain volume were similar. And then in the paper, in a randomized sample, there was no association between ventricle size and cognition. But again, that's a secondary outcome. The trial was not powered for this particular thing. However, 2 years ago, they published the results. They kept following these patients for 2 more years, which is great. And I believe they're going to keep following the sample. So now, again, using the Baileys, the cognitive score, the brain volume did predict. So less brain volume did equal poor cognitive. But again, ventriculomegaly or CSF volume did not have any association with how well they're doing cognitively or neurodevelopmentally. Now, you can criticize these studies, no problem. That Bailey's is a weak and kind of a gross outcome. It's too gross. It's not granular enough. What we need is full-scale IQ. You need the 6-hour neuropsychological test. So we last year or 2 years ago, I can't remember, we published this study. So looking a prospective study to get rid of that, and we look at it neurocognitive. And this was an HCRN study sponsored by the Hydrocephalus Association, and 8 centers at that time of the current 14 participated. So this is a prospective study. So all new patients with hydrocephalus were eligible, all etiologies, and they had to be school aged. They would get MR, baseline neuropsychological testing, GPAs, and then the surgeon would decide shunt or ETV, and then we do all that testing again at 6 months. So suffice to say, it's a very select population. The study was 60, but again, prospective. So this is an older sample. These are not babies anymore. These are older. What Benedetta would say, like, was arrested or compensated in most cases. And then the ventricle size was pretty decently large. The frontal occipital horn ratio is 0.5. So let's get to the results. So this is a comprehensive, only 60 patients, but we looked at a lot of outcomes. We looked at GPA, we looked at quality of life, and we looked at neuropsychological. And you can see all those dots, and the red line is what matters. So only 2 out of 36 showed any relationship with large ventricle size and poor development. So what about full-scale IQ? That's our go-to. So there was no association. That line is very flat between ventricle size and your IQ in school. So again, then what about the change in ventricle size? And then because maybe the hit was all taken before treatment, and then remember, these are treated, and so only 1 out of 36. And that was the state of the literature until a month ago. So this is a study that I think everyone should read. I love it. I was a reviewer, so I had a special early view of it. But this is Jack Fletcher, obviously a giant in neuropsych. And this is a follow-up from the MOMS trial, okay, that we're all familiar with, for myelomeningocele, prenatal versus postnatal closure. So all the previous stuff I talked about was for treated ventriculomegaly, but what about untreated, like our case? Because that's the one that terrifies us, you know, that because everything Benedetta says is going on in my head. All those pathological pictures are spinning around in my head and causing me anxiety, right? School age follow-up. So these are the mom's babies that have now grown up, and they're at school. So again, the purpose of this study was to compare, so who's doing better, prenatal or postnatal? And just to jump to the finish, they're doing the same. So in terms of cognitive ability. That's why it's in JNS and not New England Journal. If it was a big difference, this would have made a monster splash, right? However, there's a hidden gem. This is a great paper, but hidden gem. So there, they looked at these patients, and no matter whether they're prenatal or postnatal, they put in 3 groups: shunted, no hydro at all, so ventricles normal, and then unshunted, big ventricles. Because remember, it was the prenatal closures that invented this concept of maybe we can sit on asymptomatic big ventricles, right? It was the parents that went through hell with prenatal surgery that said, hey, not so fast with the shunts, and sort of birthed this movement, right? So this is the group I'm very interested in. So the unshunted ventricular, so obviously the kids that are unshunted have, in this graph, you can see bigger ventricles. The 2 box whispers that are high show the bigger ventricles. Those that were shunted or those that didn't have hydro have small ventricles, just proof of principle there. But they are indistinguishable from the no hydro group. So here, it's a big table, but don't don't stress too much about the big table. So just, these are a bunch of neuropsychological tests. And there you see what I've highlighted there, the no hydrocephalus, so small ventricles versus the kids that have not been shunted, or ETV for that matter, and have bigger ventricles, and they're indistinguishable. In fact, in many cases, the kids with big ventricles are outperforming the kids without hydrocephalus. Now, this is a complicated population, myelin seal, so this is unadjusted. But also, you can also see, though, the proof of principle that the shunted kids are doing way worse than the unshunted kids, which is not surprising, right? So it also tells us we're doing a great job of selecting. So back to our case, based on all that data, I'm very comfortable doing nothing. So he's doing great clinically. His head is of reasonable size. You saw that head circumference was breaking percentiles. Everyone's anxiety, everyone's flapping their arms up and down. Oh my God, it's a big head, big head. But then now I've uncovered the second half of that graph, and you can see the head, yes, it's above the 95th, but it's leveling off. It's at the same growth pattern, non-accelerative than his peers. He just will have a bigger head. And maybe that's bad. I don't think so. But now, and so I'm comfortable following him. Maybe you disagree. Okay, so Benedetta and I also wanted to just talk about, as you saw, she wanted to talk specifically about the preemie IVH population. So I'm also just going to touch on this. So what about ventriculomegaly in premature infants? As I tell my trainees, like, I purposely call these patients fetuses, or feti, I guess, versus babies, just because they behave very differently physiological in many cases. So X27 weaker, we're called 2 weeks later, grade 4 IVH, ventricular enlargement, but is doing well, intubated, fontanelle soft and flat, OFC is stable. Just to prove that the ventricles went up, and you can see the grade 4 IVH. So previously, it was the Wild West. And then the ACRN, under Jay Welland, sort of wrangled the troops, and we all got together and said, okay, let's all start doing it the same way, and this is the algorithm. But you'll notice that it's not just ventricle size, but there was signs of raised intracranial pressure had to be a part of treatment. You had to have 2 or 3 of these things. And that was to test the hypothesis, what was better, reservoir or subgaleal shunt, which showed that they were the same. That was the purpose, but then the HCRN had continued to use this protocol, which involved ICP. However, there's a recent philosophical change towards treating on ventricle size only, okay? This is mostly driven by neonatology, and they claim to have clear evidence that shows this, some of which Benedetta showed, okay? But in terms of their clinic, those are pathological papers, but in terms of clinical papers, a colleague of mine here in Calgary, Lara, when she was at Sick Kids, published this paper, and this is the paper, this is the graph that everyone will show you that says you should treat even if they don't have ICP problems. Because look, on this side, early intervention, they're doing better than late intervention. But in science, details matter. And people say, oh, you're a clinical epidemiologist, you care about the minutiae of the studies. Yes, we should all care about the minutiae of the studies, because some studies are misleading. And so when someone shows you this graph, please note that those p-values are comparing treated with intervention and without. They're not, in no way did this paper ever compare early versus late. There's not a single evaluation of that. But yet the comments, their conclusions were early is better than late without any proving that principle. Here's a table showing the same thing. Also, like, there's a few other study flaws, like when that's your consort diagram, that's your muddled population with some of those boxes having 2 or 3 patients in it. I don't think you should change practice based on something like this. I'm not saying it's not interesting or fascinating and deserves further study. Absolutely. But this is not practice changing. And the journal it was published in agrees and called it class 3 evidence. So what we need is a randomized control study. Okay, we got it. Elvis, okay, out of the Netherlands. And basically looking at early versus late, so that's 97th percentile versus 97 plus 4, right there. Now, in the most practice in, I don't know Europe, but in North America, we consider both of those early at that time, not anymore. And the outcome was death or VP shunt. They didn't show the primary, but there's VP shunt, and this is the results of the trial. It's very small, but I'll help you out with print. Negative. Okay, negative. Like listening to the authors, you would never know it was negative, but it's negative. Okay, so then what's better? So here we go. 2 years later, this is great. The Elvis at 2 years. This is what we were waiting for. So this is great. So this is the paper. And then what I've highlighted there for you is what now neonatology claims is ironclad, doesn't need anything else. So that the like the early beat the late after correcting for gestational age, severity, and weirdly cerebellar hemorrhage. And you can see that p-value, 0.03. Okay, so that's what they'll tell you. Oh, here comes our box whisker plots again, which again are comparing not early versus late. However, this time they did provide a table comparing all the cognitive, again, Bailey's, low versus high threshold. But please note that the p-values are all not significant. The univariate p-values are not significant, okay? Then you'll say, well, wait a minute. Why would they put that in the abstract that it is significant? Well, it's right there in the abstract that when they went head-to-head univariate, it was not, and it was the multivariate was positive. Now, some people and methodological geeks like me would say, well, you shouldn't really do a multivariate if the univariate's negative. But I see what they did. They think there's a signal in the noise. Please remember it's a post hoc analysis, so that's always limiting. But this is really, I'll save you the time to read the paper, but the composite outcome is death, CP, or Bailey's less than 2 standard deviation. You see the difference, 13 versus 15, 16, 23, 9 versus 18. In 126 patients, they do not have the power to examine any one of those 3. That's why they put it as a composite, because together it shows a slight signal. But again, very interesting. They've maybe found a signal in the noise, but this is not practice-changing level of data. Okay, this is, let's do a proper randomized control study. So back to our case number 2. We did do a reservoir at 29 weeks. We shunted at 42. We now treat earlier, so we are drinking that Kool-Aid. But it's really critical, and this is all I would say to the audience, is to remember that even though we're treating ventriculomegaly without symptoms in fetuses, in prenatal children, it's based on the flimsiest of flimsy evidence, okay? I was on a recent call, a pan-Canadian call, that we should all treat, like set up an algorithm for all of Canada. And somebody on the phone said, and I said, well, the HCRN is thinking about doing a randomized control study. And they said, well, I wouldn't randomize. It's unethical to randomize. So it's that sort of, that's based on flimsy evidence. I would just ask the world to say, we can't be that dogmatic on flimsy evidence because it's not that clear. And we need a real randomized control study because there are problems with treatment. You know, that's what's lost a lot of times when we talk about asymptomatic ventriculomegaly. People act like shunts have 0 complications. Treatment has no complications. Oh God, we can't leave this child, but it has no complications. So this is a preemie patient who had severe decompression hemorrhages from a reservoir and is neurologically wrecked with one of the worst statuses I ever saw. Is that common? No, but it's just as a cold water in the face that treatment also has risks. Thank you.
Jay, great talk. It's lovely talk. Both talks were very nice. Before I go any further, I just want to convey a message from Shlomi Konstantini, who's actually in the audience. He wanted me to remind you, but I think you mentioned something similar, that the endoscopy trial, the IIHS that we did with ABCO Carney, again, it showed no difference on the ventricular size. For this small group of aqueduct stenosis, pure aqueduct stenosis, no difference of the impact of the ventricular size. Anyway, before we start discussing, I just want to pick up upon a point that you made, Jay, at the beginning of your talk. definitional terms. What is hydrocephalus? Okay. For me, hydrocephalus was big ventricles with pressure. Okay, we all agree. But then again, later on, other things came along, neurodevelopmental issues, this, that, and the other. And now there's no definition, because as you said, if you say this kid has hydrocephalus, you have to treat it, treat the child. If the child has a disease, you have to treat the disease. So before this topic, we need to decide what is hydrocephalus, because once we decide what is hydrocephalus, then we go on and decide how we're going to treat. And I would welcome your comment on this and Benedetta's comment. What is hydrocephalus for both of you? Jay, go first, please.
Well, like I said, like I just, it doesn't really matter. I just needed to draw in my life and my career. I need to draw a line, and you can pick the line anywhere, but that is it. I mean, it is enlarged ventricles with signs or symptoms of raised intracranial pressure. Now, that can be headaches and like Benedetta's patients, like obscuration of vision. I'd say that was positive. Like all those are yes. And then the newer thing is just that some signs and symptoms of raised intracranial pressure is worsening school performance or deteriorating neuropsychological. I think my definition holds as long as you bring in the new age neuropsych development and quality of life as well. So.
Yes, I'll pick up on that. But Benedetta, what is hydrocephalus for you?
Well, I don't think that we should confine hydrocephalus with ventricular size or necessarily associated to ventricular size, because we can have IIH, we could have low pressure hydrocephalus. So I think the key word in hydrocephalus is progression, and progression not exclusively to ventricular size, but could be progression of symptoms, progression of raised intracranial pressure, and all of that. So as I said, there are multiple variables to consider, and ventricular size is only one of them. And that's why sometimes mistakes can happen, because maybe we focus too much attention on ventricular size. So let's, we all have ventricular.
Oh, no.
We lost it halfway.
She was making a good point. So
ventricles are the same.
Purposely frozen.
Yeah, doesn't mean. Yeah, so the ventricles are the same, and it doesn't really matter, because some patients don't have a progression of ventricular size, but they have progression of ICP. So we just need to be careful about sending the right message in that respect. There are a lot of trainees as well. So having stable ventricular size doesn't mean that there isn't hydrocephalus.
Okay, let me just, before I ask one question, let me just read to you a question from one of our friends who's following us. He says, isn't it the real issue that the brain has a lot of reserve, and we are trying to define how much reserve the patients have to exhaust before they decompensate? Has the HCRN got a means of measuring the reserve other than simply following the child clinically until they compensate? Okay, so this is a question. Also, there's a question earlier before that. There's a question for Jay. Why Dr. Cambrin is not surprised when shunted patients did worse? Okay, Jay, you may want to answer that later. But let's just talk about this question. Has the HCRN got a means of measuring the reserve other than simply following the child clinically until they decompensate? Comments. How can we measure then the brain reserve of a child before it's too late? I was actually going to ask you the same question as well, but anyway, let's just answer this question from our.
If I start, like, I think what also is lost in here is ex vacuo, and so as what do I tell parents? They're like, but I got big ventricles. I'm like, yeah, but you had a hit as a child. You had like a bleed and say an AVM or something. You had high ICP, and then now you're left with bigger ventricle. Again, it's not how your brain looks, it's how your brain works. That's my very common line in clinic. Why do autistic kids have beautiful looking brains on MRIs, and some of them are completely non-functional? And
So-
some people, university professors have terrible looking brains, and they're university professors. So again, the ex vacuo has a role in this, and so I don't think it's fair to always say that every big ventricle is compensated. I don't, or that's just the picture of your particular brain, because compensated implies that you have like a sword of Damocles hanging over your head, and it's going to decompensate and boom, like you're going to get hydro at some point. And I don't buy that personally.
So
Benedetta, sorry.
I will ask a question to both of you to get your advice. I have a child that had an IVH. It was a premature child, had a hemorrhage, and now has moderate ventricular dilatation. The child is well. Now the child is 7-8 months old. I'm following the child. I don't know what to do. How can I measure the neurodevelopmental status of that child, ladies and gentlemen? Please advise me. How can I?
Please, you go ahead.
I mean, it's only 7 months. So 7 months is difficult, as we all know. The real neurodevelopmental check is at 2 age.
Tell me about 12 months.
Okay, 12. So the most reliable one is at 2 years of age, right? So that period, then it is the clinical picture that you need to look at, because also papilledema, is still an open box. Therefore, let's say that this is a safer period, because if we talk about brain compensation, that's where you contrast it more. So in absence of any problem in terms of symptoms related to ICP, increasing head circumference, fontanelle, suicidodiastasis, the usual, then I would be reassured that vigilance would be enough. But I have personally always a very low threshold with development. The thing is that development can, again, in terms of etiology, is multivariate. Prematurity itself would be a risk factor for a neurodevelopmental problem. So it's very difficult then to make a distinction. But if they come at 2 years of age and there are still issues in terms of development, I have a low pressure to do an ICP monitoring personally.
But somebody else would argue, if you wait until the age of 2, you may have missed the boat.
Yeah, but you're not doing nothing. Like, I like Benedetta's comments during her presentation that she likes progression. You know what I mean? So in progression in 0 to 2 year olds is regression, right? So this idea that you don't have anything in a baby, you don't, they're born with ICP monitors. It's called the fontanelle, right? So it's wonderful. Like, nature has provided us an ICP monitor, which is wonderful. And then on top of that, you have a constant ICU nurse called the mother or father, who looks after every second, every day, and watching the progression of milestones. And so yes, we don't have papilledema. Yes, we don't have other stuff, but we do have ICP monitoring, and we do have development, and development's not nothing, like, I know they're gross, like walking, crawling. And if you really want, you can have Bailey's. Not many people do Bailey's outside of studies, but.
Okay. Can I just read you some other questions as well? One of our friends says, does this evidence presented hold for multiloculated hydrocephalus? Before you rush to answer, because it's a big issue, multiloculated. And another comment says, I know this is a pediatric focus, but I'm studying MPH in older adults, and I'm very curious to see if you would have similar recommendations for them. Do enlarged but stable ventricles need shunting, especially if a CSF tap test is negative. And Dr. J. Riva, thanks for the great talk, you too. You showed us studies which consider cognition in children for shunted or unshunted, but did any of those studies look at outcomes like sports performance? So let's just take one by one. Because each question is an hour talk, just little snippets of answers. What do you think about multiloculated hydrocephalus? Both of you.
The quick and dirty is that almost every study I presented, multiloculated is excluded. So you don't have any evidence to work with. And so Yes, nothing I reported.
Do you know why multiloculated is excluded?
Almost always it's excluded because
Yeah,
it's
you know why? Because all the people that do the study have very sad experiences with multiloculated hydrocephalus.
Well, it is implicit that we're talking about a much more complex condition.
Exactly.
So.
They have nothing good to say about what they've done in these patients because very difficult. Okay. Next question. What does it say?
MPH.
MPH. Well, there's another hour talk.
Well, it's a very different topic, but in general, infusion test will give you a straight answer. So a positive infusion test requires shunting. A negative infusion test doesn't. I will keep it easy like that.
Okay. And I would just say also, like, do I worry these kids that I watch with big ventricles that are stable and asymptomatic and doing great and going to university? Do I worry that when they're 60, they might get MPH or they might get Alzheimer's? Yes, I'm worried about it. And we got to do a long-term study, but that's a 60-year study. That's not going to get funded. But there's lots of people that get Alzheimer's and MPH that don't have big ventricles when they're little. So.
Jay, a comment about sports performance that is our colleague asked. Do you cognition, sports performance, and hydrocephalic children? Do you have a comment to say on this?
Well, I think that what's the ask of the question. What's interesting in that question is that are we just if I don't treat and they're big ventricles, like yes, they're normal. They can walk around. They can have a job. Maybe go to university. But they could have been Pele or they could have been Messi, like maybe by not treating them, I limited their great potential. I don't know how we ever answer that question, but we don't have any evidence for that either. If that's what
Okay. As we're approaching the end of our session, Nelson, Jeff, do you want to either summarize or give your point of view? Actually, there's no point only have the two speakers. Why don't we have two experts?
Can I throw one out to JRC? Because I've been wondering what his thoughts would be on this. I think we as a discipline may be a little bit guilty of selection of observation bias. I remember, and my team's heard me tell this story, so I apologize if anyone's on. When I was an intern on the transplant surgery service, I wondered why in the world would anybody ever consider getting a kidney transplant, because everybody was either infected or rejecting and was terribly, terribly sick, because we'd wander around from room to room and see all these terribly sick people. And what I wasn't seeing were the people that were out there in the community leading rich lives. And what has shaped our experience in Birmingham so much is our experience in the adult spina bifida clinic, where we started following these adults into adulthood, of course, and noticing initially anecdotally that a fair number of them had their original shunt or had only had one or two revisions, which was sort of completely at odds with our culture that shunts are problematic and everybody has misery and whatnot. So we said, okay, let's look at a single center. And we said, okay, so we looked at it, and about little over 40% of our patients that were followed for a long period of time had their original shunt, and another 25% had had two revisions or fewer in their entire life. And so it's okay, well, one center, who cares? So then we took it to the NSBPR and looked at the whole NSBPR, which now has more than 11,000 patients in it. And Brandon very nicely pulled that together with Kevin from the CDC with shunt survival curves. But the takeaway was that more than half of patients, somewhere approaching 2/3 of patients, have two revisions or fewer, at least in this very select spina bifida community. And that maybe that should impact our thinking a little bit as far as shunts themselves maybe have a little bit worse reputation. If you're in that 15 or 20% that has a bad course, it's terrible. But I hadn't had a chance to converse with you about that, JRC, and I was wondering, does that impact your thinking at all? How guilty do you think we are of observer bias?
Yeah, but I would throw it the other direction. Like the child, don't you always think like somebody that's like a shunt was put in by our great grandfathers in neurosurgery, and then they're now like 20 and said, I've never had a revision. sometimes I want to go back and look at those films and like, do they even have hydrocephalus? You know what I mean? Like, I'm not saying, especially in a mild population, almost certainly they probably did. But that I also think the other way is sometimes these kids that never have problems mean we're overtreated to begin with. So yeah, I agree. Your point is like, I also don't like fear mongers like, oh, a shunt is death. It's not a death. Like there's lots of people in university with a shunt. I say that as well. I just before there's also in the meantime though, like some of those people, if you ask those people that haven't had a lot of problems, but how many times do you go to emerge? Like how many times you miss school because you knew you had the shunt? Oh my God, is it the shunt, the anxiety and stuff like that? That also plays a role versus if you've never been diagnosed, maybe your quality of life's better. I don't know.
And those comments are spot on because I mean, I think that's really the challenge here is that we're talking about a heterogeneous condition of hydrocephalus that impacts a very heterogeneous outcome, which is neurodevelopmental outcome, right? Because you know, that the initial insult, the intraventricular hemorrhage, the other insults associated with dysraphism, those impact. And we have a tendency to look at this like, well, it's just the impact of our treatment of the hydrocephalus that impacts these outcomes. We treat hydrocephalus differently. That's what we're talking about. And many things beyond just the treatment of hydrocephalus impact this very multifactorial outcome. And that's what makes it really challenging.
Great. Well,
great discussion. I would like to be back just to some definition. We agree that ventriculomegaly we doesn't treat. Hydrocephalus needs treatment. I would like to listen from you. What the best definition for arrested or compensate hydrocephalus? If our definition ventriculomegaly we don't treat, hydrocephalus we treat. What about compensated or arrested hydrocephalus in your mind?
I'm not sure if we have the time to discuss all this because we're at the end of the session in LC about compensated hydrocephalus. I don't know. One word from Benedetta about compensated hydrocephalus.
Yeah, so as I said, it's the lack of progression that gives a compensated hydrocephalus. So anything that doesn't progress is, you can call it arrested, compensated, stable, whatever you want. So the definitions have evolved over time. But whatever that is progressive is definitely not arresting, is not arrested, and is not compensating.
Okay.
I like that a lot, but I'm always hesitant whenever to me it's surgeons can kind of, how you spin things to patients is how, like, I can make any patient sign up for surgery, I think, if I spend enough time with them. And by saying compensated hydrocephalus, by saying arrested hydrocephalus, it makes it like, it's like if I get my blood sugar and it's totally normal, they could say, whoa, you're compensated diabetic. Like, yeah, it's called a non-diabetic, you know what I mean? Like, so I just have, like, those are our forefathers use those terms as fear mongering a little bit, but I don't know. But I have struggles with those words. But my partner here in Calgary, Mark Hamilton, would vehemently disagree with me.
I like that term, compensated diabetic. Is a new one.
And just for the sake of variance, recognize we have colleagues, very thoughtful colleagues in Germany that are putting in programmable valves and navigating kids, changing valve settings to navigate kids through the middle of the curve, right? I mean, the spectrum of people's choices is really broad.
Yeah.
But also sometimes that's good though. Like the more that the world is doing things a bit differently, that's how we're going to find the right answer, right? So
long as we measure and do good study design, which you've been a long time champion of.
Yeah. Absolutely. I think, Nelson, we're gonna close the session if everyone agrees. I think it was a great session. Unfortunately, we have not been able to resolve the issue. No one was expecting that we would resolve the issue. And as usual, the Clash of the Titans creates more questions than provides answers, but that's the whole idea. It was a great session. It was very nice to have 98 participants, a lot anyway, over 90 participants, and some of them quite active. It's nice to see you all. And until next time we meet in the next Clash session, I hope we'll have a good time. Bye from me and all the best. Bye-bye.
Sgouros.
Thank you very much, Spyros. Thank you, Jade. Thank you,
you.
Benedetta, Jeffrey. And we will be online again for the medical students webinar next Friday, 28 April, with nursing. I encourage you to bring your young students in nursing to be with us on stage next April 28th. Thank you very much. And see you.